Good morning, everybody. Let's continue with our discussion on abnormal psychology, and we will be continuing with discussions on perspectives, biological as well as psychological perspectives on human behavior as it relates to abnormal psychology. Okay, so without further ado, let us do. And let me pull up the screen. Okay, and let me kind of get out of here and up. Alrighty. So we will be talking about contemporary perspectives, biological as well as psychological. Yeah. So from the biological perspective, what we're going to do is we're going to have a review, a very kind of quick and dirty review of some of the major regions of the brain most implicated in various areas of human functioning and abnormal behavior. So I'm going to bypass our discussion about the neurons, yeah, and neurotransmitters. We'll touch on them at some later point in the semester. Okay. Well, actually, maybe a little bit today. So let's first talk about the structure of the brain. Yeah, I want to focus on this because we're going to be talking about a lot of brain regions and parts that throughout the semester. So that, it's probably good for us to all be on the same page in terms of our understanding about the major regions of the brain. Now, one of the ways I find it helpful to understand the brain is to kind of understand it like a house, using the metaphor of the house, that there are lower structures like the basement. And as we get to the first floor, we have the living room and the kitchen. Then on the second floor, we have like the bedrooms typically, and then on the top floor, the attic. Yeah. In a similar way, I like thinking about the brain that way because lower structures tend to be more involved with basic things for the functioning of the body, like the basement is for the house, like the heater or what have you, electricity, electrical circuitry, and so on, which actually goes throughout the house. But you can think of that with the brain, right? With other, with neurons connecting from lower levels to higher levels of the brain. And then we can think of the living room, bedroom, and attic as being involved with more complex behaviors or aspects of what's going on in the house. So let's first start off with the lower brain structures, yeah? And so here we'll first be talking about the brain stem. Okay, now the brain stem includes the medulla, reticular formation, and the thalamus. Yeah. Now, look, starting with the medulla. The medulla is involved in some basic, really important critical functions. Yeah. Heart rate and breathing. Alrighty, so this is one area. I mean, there's no area of the brain you want damaged, but certainly this is one of the last ones. Because if this area is really damaged to a critical degree, breathing and heart rate will stop within about a minute or so, right? Depending on the damage. And you don't want breathing to stop because it's so critical. The brain is so sensitive to getting oxygen on a constant basis. Yeah. That any interruption of oxygen flow to the brain via the blood, yeah, within like a minute or minutes, you'll have some brain damage. Yeah. Um, so you don't want that to happen. Above it, we have what's referred to as the reticular formation. Yeah, it looks kind of like a seashell. I like to think of it as like a formation of the two hands. Doesn't it look it like clasped together that way? And the reason why I like thinking about it that way is that when I think about this, I think like a pitcher, holding her or his hands like they're holding a ball, about to do a windup and throwing the ball. Okay, and that reminds me that the reticular formation sends out, yeah, signals from the body to different parts of the brain. Yeah, that it filters and relays, filters information, yeah, sensory information. I'm sorry, information about the brain from coming from different parts of the brain and relaying it to appropriate areas. Yeah, it's also involved in arousal. So you think of baseball pitchers pitch coming at you, that's going to get you kind of aroused. Alrighty. Now, when people experience problems with, when we see problems with ADHD, attention deficit hyperactivity disorder, very often we see problems also with the going on with the reticular formation. yeah, and its ability to modulate arousal. Alrighty. And finally, we have the thalamus, which is like a mini brain, like a mini me, right? Central to the brain, right? Here's the brain stem, and here's going from the lower to the central area, like the basement to the kitchen, so to speak. And the thalamus, right? I like the reason why I say it that way. It always reminds me of the female name Sally. Yeah, I like to think of thalamus as Sally, the sensory switchboard lady, like at the phone company. If I don't know if they have switchboard people anymore, I suspect they don't. But if you can picture a phone operator, yeah, at a switchboard, she would be coordinating sensory information like visual, auditory, tactile to relevant parts of the brain. Alrighty, so that's the brainstem, medulla, reticular formation, and Sally, the sensory switchboard lady. Alrighty, now if this is the spinal cord and you this is the medulla going into the brain, this is the front, right? The eyeballs facing that way. This is the back of the brain. This area, the lower back area, is the cerebellum. Now, if you look at this, it always reminds me of someone's legs, right? The lower, as if you're looking from like from their backside upward, right? This is their thighs, their behind, right? So this is the cerebellum. I like to think of the cell. I like to think it's not. I like to think it's the case. But I like to think of the cerebellum as like a pair of legs because it's involved in the coordination of gross motor movements, particularly walking, as well as balance. Yeah, which is critical to keep the house balanced or you balanced. Right, we need a functioning cerebellum. Now, related to this is alcohol abuse. Interesting enough. Now, if someone has been abusing alcohol for decades, yeah, they may suffer what's colloquially, not an actual diagnosis, but colloquially referred to as wet brain. Okay. Now, what is wet brain? It's kind of an awful term, but it is related to problems with walking. Okay. And it's not an uncommon symptom among those who've been abusing alcohol for decades that their coordination becomes poor even when they're not intoxicated. Yeah. One example is if any of you recall the reality TV show The Osbournes, one of the things Ozzy was kind of observed doing around the house was kind of walking and dragging his feet around. Yeah, kind of like shuffling about, not really lifting his legs and, heel foot, walking, but actually kind of just shuffling his feet around as he's walking around. Well, that's very typically what wet brain looks like. Alrighty. And everyone just figured Ozzy was walking that way from his decades of alcohol abuse. Well, as it turned out, it wasn't from alcohol abuse. It actually was a poor coordination of neurological medications that he was taking. But when he got a better combination of medications, he ended up started walking fine, you know. So lesson learned, don't stereotype your heavy metal musicians. Alrighty, now going more centrally, yeah, we have the limbic system. Now, the limbic system is involved in a lot more complex processes that we associate with human beings, emotions and memory. Okay. Now, in terms of emotions, one critical area is the amygdala, right around here. Okay. Now, the amygdala is involved in the modulation of fear as well as aggressive behavior. Yeah, so flight versus fight. Some very primitive instinctual responses that occur automatically, but which we can modulate consciously as well. Okay, and when people seem to have problems with violent behavior, lo and behold, it's usually that region which is seemingly um, having seems to be dysfunctional in some manner. Yeah, or you can actually see in brain scans, MRI scans, that there's some kind of structural problem with the amygdala. Okay. Now, the hypothalamus here is involved in other um, uh, um, functions. And in particular, it's related to what's referred to as maintenance functions or duties, yeah, such as eating, sleeping, and sexual behavior. Alrighty. Now, as you may recall, I referred to the thalamus as Sally. Sally, the sensory switchboard lady. So I like to think of this, I'm going to sound a little awful, as hypothaly. Okay, so hypo implying lower or less Sally. So let's think of less Sally or hypo Sally as someone who didn't, as she didn't go to, she didn't attend to her school grades as well as her sister Sally. So hypo Sally ended up having to be a maintenance lady or janitor. Oh, I know it sounds awful, but bear with me. It's a memory device for myself. Alrighty. So what it does the maintenance lady have to do? She's involved in some basic functions, yeah, like eating, sleeping, and sexual behavior. Alrighty, not this sensory information like visual auditory information. Alrighty, it also controls the master gland, the pituitary. So guess what? Hypothaly is involved in a lot of important stuff, but more maintenance stuff. Alrighty, and finally we have the hippocampus, which is right here, which has important role in memory consolidation. Yeah, it seems to have play a role in the brain's determining whether to put something to long-term memory, preparing it for long-term memory, or whether it's um, you know uh, or whether those memories are just allowed to dissipate. Alrighty, so it seems to be where that working platform for the brain seems to occur in terms of what to do in consolidating memories. Okay, the hippocampus. The way I remember hippocampus is involved in memory. You know the old saying, elephants have great memories, which I don't know why people say that, but they say that. But instead of elephants, I think hippos. All right, bear with me. All right, I'm trying my best here, folks. All righty. So that's the limbic system. And finally, we're not finally, but we're getting to the higher brain structure. So we're thinking about the second floor with the bedrooms and the attic. Okay. Now, right off, let's talk about the attic, the cerebral cortex. Yeah, that 1 or 2 millimeters of gray matter, right? Tissue, brain tissue versus white matter or tissue. And the difference between the two is that the gray matter is where we have billions of neurons, right? Uh, in which all those multiple complex connections are made, yeah, which are involved in complex thought like logical analysis. Whereas white matter, right, which is in the lower parts of the brain, is facilitates coordination of that information. Alrighty. Now, what allows for complex human thought? Yeah, which allows us to write poetry or come up with complex or make nuclear energy plants or bombs. What allows us to do that as opposed to other species? Yeah, what has to do with the type of cortex and the proportion of cortex that we have. Now, as a general matter, right, there are three: the motor cortex for coordinating motor movement, sensory cortex for coordinating sensory information, and finally the association areas. Yeah. Now the association areas are where the billions of multiple connections between or billions of neurons are made. Yeah. And because of that complex map of interconnections, yeah, that seems to be related to our ability to think logically, think in complex ways, integrate visual, auditory, other information, and to create all the wonderful things and some awful things that we do. Alrighty, but it's the proportion of association areas compared to other species. Yeah, so if you look at mice, cat, and chimpanzee, they all have this yellow. Well, it's yellow for illustrative purposes. Association areas. Yeah, whereas the proportion of association, which here in this illustration is color, is in yellow, right? We have proportionally way more association areas than other species. Yeah. Another part of it is the complexity of convolution. See all the kind of wrinkles that you see here? That seems to be involved in the complexity of neuronal structures, right? The complex connections. Yeah, that it seems to be somehow also facilitated by the number of convolutions, which again humans tend to have more of. Okay. These two strips here refer to parts of the cerebral cortex that are related to, in the pink, again, for illustrative purposes, motor functions, and the blue for sensory functions. Alrighty. And then below the cerebral cortex, let's talk about from there and in the lower area, right? The ballooning hemispheres. Right. For most human beings, the left hemisphere is primarily, not exclusively, but primarily involved in language functions. Whereas the right hemisphere, it tends to be involved in visual spatial functions. Alrighty. Now I want to make it abundantly clear. It's not that only the left is involved in language and reading and writing, and the right is involved in visual stuff like playing a piano or paint or being a painter. Yeah, it's all parts of the brain are coordinating among different regions to perform those tasks. Yeah. Here we're talking about primarily the left hemisphere having language functions and the right having visual spatial tasks, being involved in visual spatial tasks. We can also talk about the brain being divided into different lobes, and here four major lobes. Yeah. The first we'll talk about is the occipital, which is the opposite of where the eyes are, and is involved in visual coordination of visual information, processing of visual information. The parietal lobe tends to be involved in processing of complex thought, logical reasoning. The temporal region is involved also with complex analysis, but also with the processing of auditory information. Yeah, so maybe no surprise that it's right connected here with the occipital and fronting the frontal lobe. Alrighty. Now the frontal lobe is associated with a lot of complex thought processes that are really associated with being human. Yeah, and they involve processing, being able to think in terms of time and the future. Yeah, and it goes to planning, having objectives, organizing things, and so on. Yeah, so huge, complex cognitive functions which we associate with being human. And centrally, we have the corpus callosum. It's a bundle of fibers that connect both the left to the right hemisphere. Yeah, that coordinate all the complex functions among different regions and parts of the brain that we just described. Yeah. As an aside, musicians, not just people who like music, but people who play a instrument tend to have a slightly larger corpus callosum than most people. Okay. And part of it is because of the coordination of tons of information, visual, spatial, auditory, emotive, memory, and that's one of the things that's a wonderful thing that's been found among about playing a musical instrument. Yeah, that it seems to light up almost the entire brain, because it involves so many different operations at the same time, the ones that I just mentioned. I mean, there are different activities, obviously, like reading or playing football, which light up different parts of the brain, but nothing like playing a musical instrument, or at least at this point, from what we understand, nothing like playing a musical instrument. I'm going to skip this part of discussion about the brain. And actually, I'm going to kind of pause here for a moment. Let me just check. Stop share. So just let me continue. Sorry about that. Just had to bypass some slides, which we'll take a look at later as part of our face-to-face conversation about this material. All righty. So let's continue with psychological views of human functioning. We're just going to look at some of the major perspectives. Yeah, there are certainly hundreds, if not thousands, of theories related to all kinds of different mental disorders. Yeah, what we're going to take a step back and try to consider some of historically, but as well as currently, some of the major perspectives regarding human behavior. Yeah, this again, like the biological, this is going to be just a quick and dirty review. Alrighty, so let's start. Let's start with the what I think arguably can be considered the first modern psychological view of human behavior. Um, uh, psycholo- uh, uh, that we can think of a psychological theory of human functioning, and that's Freud's theory of personality. Okay, as you may recall, um, Freud posited that there are three levels of consciousness: conscious, preconscious, and the unconscious. The conscious is kind of like what you're experiencing now. Hopefully, what you're experiencing now, which is hearing my voice and being aware of your thoughts and what you're saying to yourself. Maybe if you're writing notes, you're being conscious of you're typing or you're writing on a piece of paper and so on. All right, it's what we're our awareness of the environment, okay, and sensations and so on. The unconscious is all the stuff we're not aware of. Yeah. And for Freud, now, first of all, before I continue, I want to make it abundantly clear. Yeah. Um, Freud's theory of personality functioning has not survived empirical scrutiny. Yeah. It is not supported by science. All right. His views. What his genius was, in my view, is his observation of human behavior. So what he saw and documented, I think, and how he related it to abnormal behavior, in terms of his observations, I think he was a he was a genius in terms of things he noticed and connections he made. Now his theory, though, not supported by science. So just keep that in mind. So the underlying theory, how he explained it, his observations, yeah, that's a problem. That's a big, huge weakness. All right. Getting back to our discussion, though. So the unconscious are all the things we're not aware of, including, according to Freud, hostile sexual impulses that we don't want to allow ourselves to become aware of because of societal mores or our own personal values. And the preconscious are those things which can come to conscious come arise to consciousness, but are things we normally don't think about until someone raises it to our consciousness. Like if I were to say, "Hey, think about Thanksgiving dinner a couple months ago." Okay, you probably weren't thinking about it, but my just mentioning it probably brought it to conscious awareness. Okay, now I'm going to bypass this and get to his stages of psychosexual development. Now, for Freud, human personality or functioning, yeah, arose is primarily formed in the first 5 years of one's life. Okay, so from infancy through early childhood, and then at about that time, at about age 5, it's pretty much set. Which again, the research does not support. But let's just talk about the historical perspective. Yeah, um, and one of the things, reason why I'm talking about this is it's important for us to appreciate what Freud observed. And one of the things he contributed, which is still with us today, and for good reason, is the importance of childhood childhood experiences to later functioning, but also the effects of trauma on later functioning, as well as importance of development, psychological development. Yeah, that they go in stages and things occur at certain times, and that what occurs or doesn't occur can affect later functioning. Those observations, spot on. Yeah, how he explained those stages, yeah, not well supported. And let's touch on that for a moment. Um, Now, he posited that there are 5 stages of psychosexual development from infancy through age 5. Yeah, I'm going to go through this kind of quickly because you probably heard about this in Psych 1000, maybe in development. We don't offer personality very often, if not probably rarely offer it. But here we go. The first stage was the oral stage. Yeah, and he posited that through development, there's this energy, this kind of life energy, which he called libidinal energy. Right? It's associated with sexual behavior, but sexual behavior is just part of it, right? It's really about being connected to people, yeah, and love and attachment and all that kind of stuff. All righty. Now he posited that if a child as an infant, right, is regularly fed and nurtured and cared for, breastfed as he focused on upon, the child will develop a balanced relationship, yeah, trusting relationship with people. However, if there's some kind of traumatic experiences that occurs during this time, yeah, like let's just say the infant has an alcoholic parent who doesn't attend to the child, right, because he or she is just, drunk and unconscious, not in terms of like the levels of consciousness, but just, just passed out on the sofa and not attending to the infant, that kind of traumatic experience of not being fed for hours and hours on end can lead to fixation of that libidinal energy. Yeah. And then what will happen is that that energy will kind of be stuck at that stage. And if it's stuck at that stage, yeah, we see later behavioral problems like substance abuse or being a dependent personality disorder, suffering from a dependent personality disorder. Yeah, same thing with the anal stage between ages 2 and 3, with patient, loving, understanding toilet training, right? Because for Freud, toilet training represented the infant now having to learn to control their impulses, right, to function in society, because you can't walk around and poop whenever you want, right? At some point, well, you did when you're an infant, but at some point when you're about 2 or so, people are going to start training you to use the toilet because you can't go around. You're not going to succeed in this life pooping everywhere or wearing a diaper. As cute as that may be on some people, it's a horrible idea, right? So through careful, loving, patient, understanding toilet training by the parent, right, the person will be able to coordinate their impulses, manage it in a reasonable, functional way. But if a child goes through toilet training with a very aggressive, abrasive, punitive parenting, right, you'd have fixation at this stage, which could be associated with problems like obsessive compulsive disorder or control issues. The phallic phase, which occurs during 4 and 5, deals with one's relationship, sexual feelings that one feels towards, well, Freud focused on heterosexual relations. So later touched on, had some, wrote some things on homosexual relations, and I don't even know if we call it bisexual, but homosexual relations, and regrettably, he pathologized homosexuality. Okay? But when looking at heterosexual functioning, he saw that children had a sexual attraction to the opposite gendered parent. Not adult sexuality, but those feelings of wanting to be wanting to have a loving connection with the opposite gendered parent. Yeah, and even having fantasies, not adult fantasies, but fantasies of being married to the opposite gendered parent. Okay. And when the child realizes they can't have that parent, right, because society says, no, that's incest, big no-no, right? That fixation of energy can either go towards a functioning way of dealing with those feelings, like, you know, uh, adopting a male or female gender role so that they can get their own opposite gendered partner and not their parent. Or it may be stuck, which may lead to problems. Like, for example, what he would consider homosexuality a problem, pathology, right? Which would arise from this being stuck, this energy being stuck in the phallic phase. Okay, later, I'm sorry, I may have said that all five stages were in the first 5 years. He saw that basically personality functioning was pretty much set by the third stage or phallic stage. However, there's still some modification of personality through the latency stage between 6 years and age 12. And then the genital phase where one learns, develops, goes through puberty and develops adult sexual interactions. Okay, we'll bypass defense mechanisms. Let's talk about the learning models of human functioning. Now, the learning models, Freud's arose around the turn of the 20th century and developed it through the early 20th century, and I think Freud passed in about the 30s, or at least most of his significant writings ended in the 1930s. All right, and he had a big effect on our thinking about human functioning. Yeah, rightly in some ways, wrongly theoretically, as I mentioned before. Alrighty. In the 1950s, we had the development of another perspective, and that was the behavioral perspective. Alrighty. Radically different. In part, a reaction to Freud's understanding of um, of human functioning, but also a perspective on its own, not just a reaction to Freud, but on its own based on animal research, yeah, and observations of how animals seem to learn, and so on. So the idea of learning models is that by applying classical conditioning and operant conditioning frameworks, we can understand human functioning, but we can also understand human dysfunction, yeah. And that for actually what's really kind of wonderful in my view about, not just my view, but many, is that what's really kind of cool about behavioral learning models is that they tend to view diagnoses, mental disorders, as not something, not as a duality like normal and abnormal, yeah, but rather it's just learned behavior, just whatever we like to call abnormal or diagnose is only a learned behavior. It's no different than the stuff we call normal or wonderful or great. Yeah, everything's learned behavior. The issue becomes if it's helping someone or not helping someone. Is it allowing them to adapt to the environment or not? Yeah. So if someone is suffering from a depression, yeah, instead of referring to them as a depressed personality, or as Freud would say, maybe someone's unconscious hostility that's very repressed, right? That depression is just a problem of living. Yeah, that the person has a problem, difficult. They haven't learned good ways to get positively reinforced. Yeah, and so on. And that most disorders can be, and truth of the matter is, most disorders, even today, yeah, there's almost always some kind of behavioral learned component. Yeah. Now, as we also understand now, almost every mental disorder has a biological component because, right? Because any mental disorder arises from the brain, and the brain is a biological um, um, object. Alrighty. So there's always a biological component, but there's almost always a learning component too. Yeah. Um, and this affects not only how we conceptualize it, but also how we treat these problems. You have the problems of learning. Yeah. First of all, you assess the situation in terms of the ABC model. Yeah. You try to see what are the antecedents, the stimuli, which stimulate certain behaviors, yeah, bring about certain behaviors, or cues for certain behaviors. What are those behaviors? Yeah. How adaptive, maladaptive are those behaviors? And then how are they reinforced? What are the consequences? Yeah. How's the behavior positively or negatively reinforced? Yeah. How's it positively or negatively punished? Okay. So it involves classical conditioning model as well as the operant conditioning model. Okay. I'm going to just touch on this very quickly. As you may recall from other classes, we have a reinforcer is anything that increases the probability of a behavior. Right? It's a consequence that follows a behavior that increases that behavior, the probability that that behavior will occur. There are two kinds of two kinds of reinforcement. Yeah, one is the presentation of something positive, positive reinforcement, or the removal of something aversive. Yeah. So positive reinforcer might be like giving candy after someone's behaved well, right? You can think of a token economy system. We'll touch on that a little later, perhaps. And negative reinforcement, the removal of something unpleasant. Yeah. So what would be well, certainly that's a way we can understand a lot of phobia and anxiety disorders. Yeah, that people are avoiding, let's say, social situations because it produces so much anxiety that when they stay home and don't phone anybody, right, they remove the anxiety from being with people, and that just reinforces staying home behavior or not calling people up and stuff. Punishment, you can think of two types. The presentation, positive punishment is the presentation of something aversive, like spanking a child when they, were nasty to their sibling, right? To decrease the nastiness behavior, or negative punishment, removal of something positive, right? So if the child likes, playing on the iPad, but, you just found out that they were nasty to the sibling. You snatch the iPad from, well, not rudely, but you take the iPad from the hands and you go, Johnny, you can't play with the iPad for the rest of the afternoon because you're nasty to your sister Mary, right? And so that's a removal of something positive to decrease his nastiness behavior to his sister Mary. Alrighty, so reinforcement and punishment can play out in a number of ways with a lot of disorders, and we can see this how it plays out in phobias and depression and many other types of conditions. It's just a very helpful framework, and what's helpful about it is that it allows us an operational model, yeah, by which we can collect observable data and understand it scientifically, and then to apply scientific methods, right, to modify or change that behavior. It's not about diagnosing conceptualizing the person as being a certain personality. Yeah. In fact, some schools of behavioral thought, kind of disavow the notion of the construct of personality. All that matters is the stuff we can observe. Yeah, the behaviors, but looking at it as depressive behaviors, anxious behaviors, eating disordered behaviors. Okay. Now, let me stop here just for a moment. Okay, thank you. Just had to take a break. uh, Red Bull break. Um, all right, let's look at the cognitive theories. And cognitive theories of, related to abnormal behavior posit that the kinds of problems people suffer from, are not only problems in behavior, but are related to how we think. Yeah. And that probably makes intuitive sense to most people. Alrighty, that our attitudes, beliefs, things we see to ourselves, yeah, images we have in our mind, affect behavior. Alrighty, and that these constructs, cognitions, are subject to scientific methodology, just as behaviors are. Alrighty, and that you don't have to see it as either or, but that they interact, cognitions and behavior. Okay. We'll talk a little further about cognitive therapy, one of the major forms of cognitive psychotherapy. Yes, CT cognitive therapy, which was developed by psychiatrist Aaron Beck. There's a picture of Aaron Beck in a red bow tie. And his view was that people maintain schemas or maps of ways of organizing, their experiences, and which allows individuals to process information. His current view, um, or the current view of cognitive therapy, is that there are these modes or networks of both thought, affect, motivation, and behavioral schemas, all kind of, and that these networks, kind of, these complex networks make up modes, and should be the focus of treatment. Yeah, not just thoughts, but understanding the network of thoughts with affect and the other variables I just mentioned. Yeah, that there are minor modes that are involved with things that aren't related to problematic behaviors like studying or having a conversation about Game of Thrones, but that there are these primal modes which, you know, uh, tend to lead to absolutistic thinking, and also, like, for example, like, I must perform perfectly, and then automatic thoughts, like, so if I say something silly in class because of my absolute belief that I must perform perfectly, I'm going to automatically think everyone thinks I'm stupid in class. Excuse me. Okay. Although referred to as or named as primal, yeah, these primal modes can be modified, but by deliberate thought as well as behavioral action. Okay. Now, we'll talk a little later about Aaron Beck's cognitive therapy and how we go about treating someone given this particular framework. Okay. The other individual key figure in cognitive psychotherapies is Albert Ellis. Okay, he's the gentleman to the right in this picture with Aaron Beck, who's now wearing a green bow tie. And Albert Ellis, I believe Aaron Beck is still alive. Regrettably, I think Albert Ellis passed away about a decade ago. And he is the founder of the cognitive psychotherapy referred to as rational emotive behavior therapy. Okay. Now, what is the difference between the two? Okay, it's more of a issue of emphasis. Yeah, whereas Beck recognized both kind of absolutistic core beliefs as well as automatic thoughts which may arise from those core beliefs. Yeah, again, I must perform perfectly, and then the automatic thought, oh, people think I'm dumb because I said something silly in class. Yeah, Beck would work with both equally, if not placing more of an emphasis on the automatic thoughts. Yeah, so if someone says to themselves, "Oh, I'll never get a date," that arises from the absolutistic core belief that I must be accepted, something like that. Yeah, he would work with the client to help them examine the reality or the accuracy of that automatic thought. Yeah. Now, for Ellis, it was the reverse. Okay, he would certainly work with the automatic stuff, but his primary emphasis was on the core belief, that core philosophy that I must perform perfectly or I must be accepted. Yeah, and he thought that it was more on target and more critical and helpful to the client if you focused more on the underlying philosophy than if you focused on the automatic thought. Yeah. Now, moving right along, we'll just kind of bypass this. Kind of touched on this already, so I'll just move along. Um, and with that, let's talk about treatments. Alrighty. So, from the biological perspective, the primary way the biological perspective contributes to our current treatments in terms of abnormal behaviors is by way of medications. Okay. Now, there are other biological interventions such as psychosurgery. Okay, but that's really for the minority of cases where you actually, damage a part of the brain in order to relieve behavioral suffering. Okay, that may be done in some severe seizures and so on, but that's really the minority of situations, and not going to be much of our discussion concerning mental disorders. Now, the other type of biological treatment is electroconvulsive therapy, ECT. Now, that is an increasingly common intervention when drugs don't work. Okay, so usually the first go-to approach with treatment is by way of psychotropic medications. So let's talk about some of the major ones, the major groupings. The first are anxiety medications or anti-anxiety medications. Yeah, the biggest classification, the most common one, are the benzodiazepines. They include things such as Valium and Xanax. Yeah, probably among the most common psychiatric medications that are prescribed. Alrighty, and benzodiazepines essentially work by decreasing central nervous system activity. Alrighty. Um, the other category are antidepressant drugs. And here you see numbered 1 to 4 are the four major antidepressant drugs that arose historically in this order. First, the tricyclics, then the MAO inhibitors, the SSRIs, or selective serotonin reuptake inhibitors, and finally, currently, this serotonin um, let's see, the selective, uh, the serotonin norepinephrine reuptake inhibitor. Sorry, got kind of stuck on the end there. Now, as a general matter, yeah, the earlier schools or categories of antidepressants like the tricyclics and the monoamine oxidase inhibitors, yeah, were effective, but had a lot of negative side effects, yeah, like dry mouth, um, problems with sleeping, weight gain, problems with a decrease in sexual interest, right? And the latter ones, the SSRIs and SNRIs, were very effective, are very effective, but without little to no negative side effects. Yeah. Now, are all four still are medications from all four categories still prescribed? Yes. And you might be asking, why would a psychiatrist prescribe a medication from one of the two first categories? Well, regrettably, although the SSRIs and SNRIs tend to have fewer to no negative side effects, for some individuals, they don't make that big a dent in their depression. So sometimes it involves having to use some of the older medications. Or to make things even more complex and regrettably more frustrating sometimes for the patient, is that it often involves some combination of the earlier types of antidepressants with the later types of antidepressants. And what can make it even more complex is that sometimes and it's not uncommon for many individuals that they have to go through different trials of combinations at different dosages. Alrighty. So the process of getting the right antidepressant or combination of antidepressants and or combination of antidepressants and dosages can be a very frustrating experience for patients. Sometimes some patients luck out and the first antidepressant and dosage they get does the job. But for many others, it is this process of experimenting to find the right combinations or right medication or combinations and then the right dosages. Alrighty. So moving right along. In terms of antipsychotic drugs, okay, often referred to as neuroleptics, um, one of the major categories are the phenothiazines. Yeah, include medications such as Thorazine, Mellaril, Prolixin. They tend to operate by blocking dopamine receptors. Yeah, dopamine having a huge role in many complex human functions like emotions, memory, reward, and so on. And for those suffering from psychotic disorders, they often have problems experiencing. Usually, it's an issue of being too either the receptors are too sensitive to dopamine, or dopamine lingers far longer in the synaptic gap than for most other people. Yeah, not so much an overproduction of dopamine, but again, whatever dopamine is produced lingering in the synapse longer than usual, or the receptors being more sensitive to dopamine than for other people. And we'll talk about ECT a little further in more detail in our chapter on depression, mood disorders. Yeah, but ECT is very still commonly used when trial of antidepressants or medications don't work. So the usual go-to is first going by way of medication and then by ECT. But ECT can be incredibly effective for depressions that are resistant to medications. Okay. So in terms of the psychological treatments, let's talk about psychotherapy. Now, generally, you can think of psychotherapy as obviously an interpersonal process in which one person communicates their expertise or knowledge to another to help them understand the problems they're experiencing and how they can change those problems. Now, what are the difference between psychotherapy and other relationships? Okay, well, it involves a person who's administering psychotherapy, right, psychological intervention to treat a mental disorder. It requires training. Requires that they got a certain level of graduate training, master's or doctorate, that they're licensed. Okay. Now, psychotherapy is not a mutual relationship. And this is something we'll talk about later, what that means. All righty. It's not like a friendship, right? Where it's equal, right? You both spend about have the same investment, care, listen, respond to each other in the same way. Psychotherapy is not mutual. Yeah, and we can talk about that a little later. And then there are also there are formal parameters. You can think of them as boundaries in the psychotherapeutic relationship. Yeah, it's not friends. Alrighty. And some of those parameters include parameters concerning time, um, you know, uh, interruptions, how one person listens to another, and avoidance of any dual relationship. And again, this stuff we'll probably chat about more when we meet face to face or on Zoom. Okay. Um, let's see. So, in terms of the types of psychological interventions, yeah, there are psychological approaches which are referred to as psychodynamic or psychoanalytic or psychodynamic. When you hear psychoanalytic, that usually refers to the classic Freudian approach. Okay, and the classic Freudian approach, is often associated with uh, lying on the couch, right, or sofa, away from the therapist, and where the person just talks on and on and on, and the psychoanalyst takes copious notes and rarely interrupts the patient, but occasionally making an interpretation about what's going on unconsciously. Okay. The idea with psychoanalytic treatment is that it's frequent. Typically, psychoanalytic clients see their psychoanalyst multiple times, sometimes 5 days a week for years. Alrighty. So not very practical. Most insurance companies will not pay for this kind of treatment. Right. So it's usually the treatment for those from middle upper class to upper class individuals. Alrighty. But this is a very traditional type of psychological treatment. It is not in vogue. It is in the minority. It's only a minority of therapists who still do this. Um, uh, but it is a form of psychotherapy that still exists. Yeah. The one that's more common that can be reimbursed by insurance companies is what's referred to as psychodynamic treatments. Now, psychodynamic treatments arise from theorists who were Freud's disciples, like Alfred Adler, Erich Fromm, and so on. Yeah. And those theories tend to be less based on unconscious processes, but conscious processes, what people are aware of, what they're thinking, what they can say. Yeah. The treatments usually involve people coming in once a week, sitting face to face across, so not lying on a sofa, and they're engaged more in a conversational type of interaction with their psychodynamic therapist. Yeah, still getting in the psychodynamic therapist still will investigate things such as the person's relationship, family relationship, early childhood experiences. Yeah, but the focus is more on conscious thought and what they're saying to themselves, what the client is saying to him or herself in current interactions, including interactions with the how they think or feel about the therapist themselves. Again, these are reimbursed, tends to be once a week. It could be either short term or long term. There are 12-week, 10 to 12-week psychodynamic short term treatments, as well as treatments that may go on for several months or a few years. That's, I'm going to leave discussions about transference and resistance to your text reading, but you should be familiar with these ideas. Now, in behavior therapy, as kind of alluded to in our discussion about the theory, the therapist and the client, right, may, and this is a very, by the way, in terms of behavior therapy, as it's more commonly referred to and conceptualized as cognitive behavior therapy, yeah, are the types of therapies which are most often covered. First of all, have thousands of studies, yeah, in which provide empirical support for these kinds of approaches, cognitive behavioral therapeutic approaches. That's one. So it has a scientific um, empirical support in large part, as pointed out earlier, because it arises from a scientific framework of examining of observables, right? The empirical approach to things. And because it allowed itself to apply the empirical approach, no big surprise, we now have thousands of studies that support the effectiveness of various cognitive behavior therapy approaches. And because of that, these are the approaches that are most commonly reimbursed. Yeah, there are other approaches as well. Yeah, like the psychodynamic short term and types of treatments, some other interpersonal, which tend to be a combination of psychodynamic and behavioral approaches, some humanistic approaches. Yeah, but the ones that are most commonly reimbursed because it has the most empirical support are the cognitive behavioral therapies. Okay, they tend to focus on what people are thinking, saying to themselves, the attitudes and beliefs as well. Well, let me take a step back. Uh, I'm going to first focus on behavioral side of these therapies. Yeah. So on the behavioral side, right, as I mentioned before, the most common types of treatments are cognitive behavioral therapeutic approaches. So I'm going to try to focus on a component of it for now, and then we'll get to the cognitive component. The behavioral component focuses on prior behavioral learning and how to change or modify those behaviors utilizing, the classical and operant conditioning models. We'll kind of bypass all this. The cognitive side focuses on what attitudes and beliefs, what people are saying to themselves, and how they can change what they're saying to themselves, either from a rational motive behavior therapeutic approach, where they examine their underlying philosophies, such as being accepted, having to perform a certain way, and if they can modify those underlying philosophies of life, yeah, that they're invariably going to change what they automatically say to themselves. Yeah. So instead of saying, if you can change the philosophy that everyone must love me, I must be accepted by everybody, and then you can change it or modify it to, I would like everyone to like me, but that's just not the case. That's not reality. People have their own choices. Some people will love me and accept me, and others won't. Yeah. And if you can change that philosophy from that absolutistic one to the more relativistic one, you're more likely to have automatic thoughts. In the former, you're more likely to have automatic thoughts. Like if, let's say, someone turns you down for a date, you're if you're in the former type of philosophy, you might be inclined to automatically say, "Oh, I'm a cretin, I'm a horrible person, no one's ever going to love me ever." Whereas if you have the latter philosophy, you're more likely to say, "It's sad, it's disappointing, when someone rejects me, yeah, doesn't want to go on a date with me, but life will go on. I can probably find somebody else to go out on a date with, and so on." Yeah, it's more relativistic. Alrighty. And the difference again between the CT Aaron Beck's approach versus Albert Ellis's approach is that Beck will focus just as much, will focus on both the core belief and the automatic thought, but as a general matter, more on the automatic thought. Yeah, having the person examine, is it true that, just because this one person rejected you, that you'll never ever meet anyone else again? Let's collect data on that. Yeah, let's examine that. Yeah, how reasonable that is, or the logic of that, or the evidence for that. Whereas Ellis will look more at the philosophy, yeah, questioning that. Because for Ellis, that accounted for more of the variance of thinking, yeah, or that this core belief is what affects your automatic thoughts. So if you want to get to the root of the problem for Ellis, it was more the philosophical, yeah. So, and with that, I think that's all I have to say about treatments. Now, I just want to be clear. Um, Let me get out of here. We just looked at some major views: the psychoanalytic, psychodynamic, um, the behavioral perspectives on treatment. Okay. I don't want to leave you with the idea that there are two or three treatment approaches. There are hundreds of psychotherapeutic theories and treatment approaches. Okay. Now, as I mentioned before, the most common ones, yeah, are the CBT approaches, cognitive behavioral approaches, for the reasons I mentioned before. Yeah. But even within that perspective or view, right, are dozens of different theories underlying why people behave a certain way, and how you can, and why these treatments are effective. Alrighty. Um, and as a general, even outside of CBT, just as a general matter, there are hundreds of different psychotherapeutic approaches. All right. The CBT tends to be the one that's most empirically supported. Alrighty, then. With that, that's all I have to say about chapter 2. And with that, the next time I see you will be in our discussion on chapter 3. All right. Again, thank you for your undivided attention, and I will see you guys later. Take care. Bye-bye.